Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and today we'll be talking about how to take care of your heart health and reduce your risk for atrial fibrillation, or AFib, and other heart rhythm disorders. We'll also discuss irregular heartbeats and arrhythmias, how they're diagnosed, and the latest treatments. We're joined today by Dr. Haddadi. Dr. Haddadi, thank you so much for joining us. Appreciate it.
Of course. Good morning, good afternoon, I should say, and thank you for having me.
Yes, of course. Then thank you to our viewers for watching. Give us a like, let us know you're watching, share this broadcast with your friends, and if you have any questions for Dr. Haddadi, please share those in the comments. All right, well, let's get to know Dr. Haddadi a little bit more before we get into our questions. Dr. Haddadi, will you introduce yourself to our viewers?
Sure. My name is Cyrus Haddadi, and I'm a clinical cardiac electrophysiologist here at MedStar Washington Hospital Center. And what that means is I am a heart rhythm specialist. I tell my patients that your heart is like a Ferrari or a Lamborghini. It's a supercar, and it has an engine, and it has a very delicate electrical system. So many cardiologists specialize in the pump and the engine, but electrophysiologists are the electricians of your heart.
All right, I love that. That's a really nice way to think about it. So let's talk about arrhythmias first, and let's explain them for our viewers who might not be as familiar with them. Can you just start by explaining what having an arrhythmia means?
Of course. So arrhythmia is very common, and what it means is irregular heart rhythm. You can have fast irregular heart rhythms, slow irregular heart rhythms, and some lucky people have both. The number one arrhythmia in adults around the world, and here in the United States, is atrial fibrillation, or AFib for short. And I'm sure that all of us are familiar with AFib because there's a lot of commercials on TV for the latest and greatest medications to treat it. We think that up to 1 in 3 Americans will develop atrial fibrillation over the course of our lifetimes.
Wow. And so in terms of types of arrhythmia, the most common would be AFib. Are there other types that are common other than AFib?
There certainly are, and when you look at a breakdown in our lovely patients, folks who are younger tend to have a slightly different arrhythmia called SVT, or supraventricular tachycardia. There's a couple common flavors of SVT, but all of them cause people to feel not their best because you get sudden onset of palpitations, fast, irregular, pounding heartbeats. It's one thing if you're at the gym on the treadmill and your heart rate is elevated, but if you're just at home on a Facebook Live broadcast and your heart rate is 150 beats a minute, you're not going to feel good because there's a distinct mismatch between what your body is asking for and what your heart is delivering. Atrial fibrillation and its cousin atrial flutter, as we mentioned, tend to affect somewhat older folks. And, we're blessed to live in a country, in a world where we get to be 60, 70, 80, 90 years old. And so a lot of these arrhythmias, you're either born with a predisposition to, or happen as a result of healthy life experience and aging. The common thread is that here at MedStar, we have a very sophisticated approach to all arrhythmias, and many of them can be treated, if not outright cured, with a minimally invasive cardiac procedure called an ablation.
All right. Thank you very much for that. Why is AFib so common?
Well, I think the best way to think about it is, as we are, again, blessed to live longer and age, you're going to get breakdown and wear and tear all over our body. We all know that no babies are born with gray hair, or in my case, no hair or wrinkles. But as we live longer, we develop these things. So unfortunately, atrial fibrillation is not quite as benign as gray hair or wrinkles, but what it reflects is that as we get a little bit older, the heart's natural pacemaker loses some of the ability to regulate itself. So instead of a nice, beautiful heart rhythm, and remember that we are heart rhythm specialists of top chamber, bottom chamber, top chamber, bottom chamber, ba-dum, 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 the top chambers start to race very rapidly and very irregularly. So that beautiful orchestra or symphony of the heart rhythm gets replaced by just a cacophony of noise. The top chambers race out of rhythm, and then the bottom chamber often races to try to keep up. And the whole effect is that people feel bad. The efficiency of the heart pump goes down. So you have a lot of symptoms like fatigue, shortness of breath, brain fog, and worst of all, because the heart is out of rhythm, blood can pool inside the heart itself and form clots. So people who have atrial fibrillation actually have a 5 times higher risk of developing a stroke than people who don't. And we think that about 1 in 6 strokes in this country is directly attributable to atrial fibrillation. So it really is a problem for all Americans because there's millions of us who have AFib, and many of us don't even know it.
Wow. So, yeah, speaking of, you mentioned a couple of the symptoms. Can can you talk about, yeah, if you don't
Of course.
if you
So
don't know, if you don't have any symptoms, you know.
the symptoms can often be really, really subtle, right? And people, especially again, as we're blessed to be 70, 80 years old, people often say, well, I'm just slowing down with age, or, I'm just feeling my age. But the fact of the matter is, you should feel good at every age. And so if you notice that you are not yourself, more tired than usual, can't do the things that you used to love, atrial fibrillation could be the cause. One of my patients is an avid golfer, and he tells me that when he is in rhythm, he can grab all of his clubs, grab his golf bag, go by himself up this very tall hill on the course. But when he is out of rhythm, even if he leaves his golf bags behind, he can't do it. So people who have atrial fibrillation, there is a distinct difference between what you can do in rhythm when your heart is pumping efficiently and what you can't do when you're out of rhythm.
All right. Thank you very much for that explanation. So Dr. Jones is joining us now. So I'm going to
Fantastic.
add him into the discussion, and we'll keep talking through our questions. So you did mention that. So hi, Dr. Jones. Are you there? While he's
Hello there.
hi there. Thanks for joining.
Absolutely.
Yeah, we're here with Dr. Haddadi. I'm Karen Zingle, and we have an audience of viewers who are watching our discussion about atrial fibrillation. We started talking about the different, what an arrhythmia is, what is AFib, why is it so common? And Dr. Haddadi was talking about how having AFib can put someone at higher risk for a stroke. And my question to you is, are there other types of health conditions that someone could get? Are you at higher risk for other health conditions other than a stroke if you have AFib?
Yeah, so stroke is certainly one of the things we're most concerned about with atrial fibrillation. And as has already been mentioned, certainly it increases the risk of stroke when one has AFib. And we normally go through what's called a CHADS VAS scoring system to determine one's risk of having a stroke. And we talk about that anytime we're meeting a patient with atrial fibrillation, and ways to manage that, including blood thinning medicines and procedures that we can perform called left atrial appendage occlusion device procedures. But certainly having atrial fibrillation puts folks at risk for other issues as well, right? And folks who have heart failure or a weak heart or a stiff heart, it can lead to fluid building up. Certainly the symptoms with atrial fibrillation can sometimes drive people crazy. People can be quite symptomatic from AFib. The two that always stand out to me are people felt like they had a squirrel running around in their chest or a fish flopping in their chest. They're short of breath when they exercise and this type of thing. And when folks are symptomatic with atrial fibrillation, that's where we really try to get them out of AFib and try to keep them out of AFib so that they have a better quality of life. And that's where things like medications can help, and procedures that we perform called catheter ablation procedures can be helpful in reducing one's atrial fibrillation burden. There's been associations with dementia and things like this. And so, I think AFib can be a nuisance for many reasons. Certainly stroke is the one that we worry about most. Blood clots can go anywhere in the body as well. A blood clot that goes to the brain is a stroke, but damage to body parts or organs can happen, wherever the blood clot happens to go. And so those are all things that we think about and talk about when we're, talking with our patients about atrial fibrillation.
Mm-hmm. All right. Thank you so much. Appreciate that. I want to talk about pacemakers next. And going back to you, Dr. Haddadi, what types of heart rhythms does a patient need, or when do they need a pacemaker?
Sure, that's a great question. So, as we mentioned, arrhythmia is very common, and some arrhythmias are slow, what we medically call bradyarrhythmias. Bradyarrhythmias, slow heart rates, can often leave people feeling very, very bad also. So imagine you're on the highway and the speed limit is 60, or if you're on the Autobahn, of course, there is no speed limit, but your car can't go any faster than 20 or 30 miles an hour. You're definitely not going to get to where you want to go on time. So it's the same way with your heart. Our natural pacemaker inside the heart is designed to beat at about 60 beats a minute at rest, and then go up with exercise. So unfortunately, again, sometimes as we are blessed to live longer and get older, wear and tear on the heart means that the pacemaker starts to become slower. It can go down to 20, 30, 40 beats a minute. And when you exercise, or even when you walk around, it loses some of the ability to modulate itself up. So people have, again, a real mismatch between what the body needs, say 100 beats a minute walking up the stairs, and what the heart is giving you. So a pacemaker is a cardiac device. It's a very sophisticated, tiny computer that we can place inside the body to gently remind the heart to beat faster, to beat more at what we think is a natural number of beats per minute.
All right, thank you. Can you talk about the different types of pacemakers that are available?
Sure. I would say in general, there are two families of pacemakers. The first family of pacemaker is what we call a transvenous pacemaker. So what that means is transvenous through the veins. So this type of pacemaker that we first invented, believe it or not, in 1958, involves a minimally invasive surgery where we make a tiny cut on the skin, make a little space under the skin, usually here in the left chest, for a battery, and then take 2 or 3 long, thin, skinny wires all the way down the vein into the heart. These wires have tiny little screws at the tip, so we screw them into the top and bottom chambers, and boom, suddenly you've restored the ability to pace the heart. So transvenous pacemakers are great, but we've also noticed that they have some shortcomings. So about a decade ago, physicians and engineers and scientists went back to the drawing board, and we invented leadless pacemakers. So as you can imagine from the word leadless, there is no lead, there is no wire. These are pacemakers that look a little bit like AAA batteries. They're tiny and they're self-contained. And these go directly inside the heart, often through a tiny incision in the groin. MedStar is a leader around the country in leadless pacemakers, and we are really enthusiastic about the benefits that these bring to our patients without needing to cut the skin or without having the bulge of a battery underneath your skin.
Great to know. Thank you. Can you talk about the difference between a single chamber and a dual chamber pacemaker?
Absolutely. So the word chamber is referring to the chambers of the heart. We have 4 chambers, 2 on the top and 2 bigger pumping chambers in the bottom. The natural pacemaker of the heart is actually in the top right chamber. We call it the sinus node. So most transvenous pacemakers, most of the old-fashioned pacemakers that we implant are dual chamber pacemakers. You thread one wire into the top chamber and one wire into the bottom right chamber. With leadless pacemakers, you have a little bit more flexibility to implant in one, the other, or both chambers. So you could put a leadless pacemaker in the top chamber of the heart if you have a slow heart rhythm. You could put a leadless pacemaker in both chambers if you have a problem transmitting signal from the top chambers to the bottom chambers. And I hope that makes sense for our audience. If there's any questions, I'd love to hear them. Or, Richard, if you have maybe a different spin on things, I really would love to hear how you explain this to your patients.
Yeah, no, I think something, very similar. Yeah, and you're exactly right. And I think one of the nice advantages of the leadless pacemaker and the newest one that's come out is, we can sometimes put a leadless pacemaker just in that top chamber on the right to mimic or take over for the native sinus node or that pacemaker we've been talking about. And in some select patients, it's all that they need. And so it provides a nice, kind of minimally invasive, no, big bulky device up here on the left, like you were talking about. A nice way to perform pacing in the top chamber only if that's what's needed. But yeah, in general, I like your example of the driving on the highway and the Autobahn, and the heart rate going too slow. A pacemaker prevents the heart from going too slow, and I think that's the key takeaway. There are several different varieties, if you will, and ways of achieving bringing that heart rate up with the pacemaker. But that's its function, is to pace the heart, to kind of, I think about putting the floor on how low the heart rate can go, and that's what a pacemaker can do. And sometimes people go super duper slow in the 20s and 30s, as Dr. Haddadi was talking about, and that clearly is probably a little too slow. Most people are going to be symptomatic with that. Some people go super duper fast in this rhythm we've been talking about called atrial fibrillation, and then when they break out of it, they go super duper slow. And that's another place where we often put in pacemakers, because it becomes difficult to manage that too fast and too slow without having that floor. The lowest the heart can go, and a pacemaker can provide that by preventing things from going too slow.
Mm-hmm. Thank you very much for that. And Dr. Jones, when is a leadless pacemaker recommended over a traditional pacemaker?
Yeah, I mean, that becomes a bit of a patient preference and a discussion that we can have, when we meet with patients and we talk about the various varieties of pacemakers. A leadless pacemaker is nice for the reasons we discussed. You don't have the battery that sits just under the skin. A pacemaker isn't super big and bulky per se, as compared to a defibrillator that we'll talk about later. But it does provide something that can be seen. It's a bigger incision. It's more visible. A leadless pacemaker goes in from the groin. We use the vein in the groin to bring everything up to the heart and implant it that way. But there are certain advantages to the traditional, pacemaker that sits under the clavicle and has oftentimes two leads going into the heart. And the biggest advantage now is what we call conduction system pacing. We have gotten really good at placing these leads in a location that provides what we call physiologic pacing. We're trying to activate the heart with these pacing leads in a way that is very similar to how the heart activates, when all the wires are working appropriately on its own. And so we've gotten very good at putting leads in just the right spot to get, a really nice result that patients will do well with in the long term. The only downside to the leadless pacemaker is that at least as of yet, we're not able to put that in kind of a prescribed location, the location where we exactly want it to get that conduction system pacing we were talking about.
Mm-hmm.
Karen, I think everything that Dr. Jones said, I agree with 100%. For me, the biggest advantages of the leadless pacemaker are when I compare it to a traditional pacemaker. Well, wires are wires. And we all, as a kid, played with coat hangers, bend it, unbend it, bend it, unbend it. And we know after a while, it'll snap.
Mm-hmm.
So a traditional pacemaker, the wires have a small but not zero risk every year of fracturing, or actually more seriously getting infected.
Yep.
And we think that a leadless pacemaker, because it has no wires, is almost immune to those risks. So I would say for a young person who needs rare backup pacing, or for somebody who may be at a little bit higher risk of infection, somebody who's on dialysis or maybe chemotherapy, leadless pacemakers should be strongly considered. But as Dr. Jones said, that's a very sophisticated question, and you're really best off asking your doctor, your electrophysiologist, well, what type of pacemaker do you think is available to me? What am I a candidate for? And what should I get?
All right. Thank you so much. Great discussion on pacemakers. So I just want to take a moment to thank our viewers for watching. Thank our experts for joining us today. As you know, we're talking with some of our cardiac electrophysiologists about how we can take better care of our heart health and how to reduce our risk of atrial fibrillation and other heart rhythm disorders. We do have more to cover, so keep watching. If you have any questions for our experts, please leave them in the comments. And speaking of our experts, we do have Dr. Shah joining us. So I'm going to bring
Welcome,
him
Dr.
in.
Shah.
Thank you, Dr. Shah, for joining. So we'll bring him into the discussion. But I do have a few questions from our viewers that I wanted to ask now. We're getting lots of questions. Thank you so
Great.
much. This one first is from Mary. Her question was, what are the criteria for an ablation? Dr. Jones, do you want to answer that one?
Sure. I assume we're talking about an atrial fibrillation ablation.
Yes.
Yeah, perfect. So oftentimes, as I was mentioning earlier, the person who does best, or really the person that we're typically looking for an ablation procedure, is someone who's symptomatic in AFib. We're trying to knock back the amount of atrial fibrillation they're having, and an ablation procedure is a fantastic way to do that. We know that it tends to work better than medications in terms of preventing the AFib that comes and goes, or paroxysmal atrial fibrillation. It reduces that likelihood of progressing to persistent. An ablation procedure does better than medications. And with an ablation procedure, we're able to target typically the most common trigger for AFib, which is these pulmonary vein triggers, or these little fast firings within the heart that can set the heart off into atrial fibrillation. And so we target that with an ablation procedure, and really try to knock that amount of AFib that any person is having, really knock it back down.
All right, thank you so much. And thank you, Mary, for that question. This next one is for Dr. Haddadi. This is from Elaine. She's asking if we deal with POTS and NMH. They are new to the area and looking for specialists who can treat these conditions.
Great. So for those of us in the audience who are not familiar with those terms, POTS stands for postural orthostatic tachycardia syndrome, and NMH stands for neurally mediated hypotension. And I think these are very, very closely related conditions. And the common thread here is that your brain-heart-body connection has become a little bit overly sensitive or overstimulated. So all of us will have small changes in our blood pressure or our heart rate when we change position, right? If I am laying down and I stand up, well, gravity will pull some of the blood, some of the fluid in my body down to my feet and legs. And the blood vessels in the feet and legs are supposed to recognize that, squeeze, and push that blood back up to my brain. But in POTS and an NMH, that reflex is not quite right. So you can have very, very drastic swings in your heart rate or in your blood pressure, and people can be very, very symptomatic. Like we had said earlier, if your heart rate all of a sudden jumps from 80 to 160, you're going to feel pretty lousy. Or if your blood pressure all of a sudden drops from 120 to 60, you're going to feel bad. You could even faint and hurt yourself. And for us as electrophysiologists, well, we all see patients with POTS. And what we have seen after COVID is that some lucky people who get COVID have long COVID. And one of the manifestations of long COVID is a POTS-like syndrome. So we are seeing more and more of it, especially in young people. And I think awareness is critical. And every single one of us at MedStar in the section of cardiac electrophysiology have patients with POTS and are working very diligently to get you all feeling better.
All right, thank you, Dr. Haddadi. So a couple more audience questions, and then I'm going to get back to some of the questions that I had. Dr. Shah, thanks again for joining us. We've talked about we talked about what an ablation is. Speaking of ablations, Dr. Jones did need to hop off to run to do an ablation procedure. So thanks to him for joining us. We talked about, symptoms of AFib, but we have a question from our audience. This is from Wendy. Wendy, thank you for your question. She asks, once diagnosed with AFib, can it go away? Help you answer that, Dr. Shah?
Yeah, I would say that it's uncommon. In our heart of hearts, we'd hope that we can make atrial fibrillation go away, but it's challenging. There might be a few rare circumstances. We know, for example, that alcohol can be a trigger for atrial fibrillation. And so if you're really to, eliminate that from your lifestyle, or if you were to lose a significant amount of weight, if you have extra weight to carry, then in some rare circumstances, that can really essentially eliminate atrial fibrillation. But for, I would say, over 90% of our patients, when you've been given a diagnosis of atrial fibrillation, it's likely going to come and go. And so for many of those patients, especially if they have symptoms, we're pushing them towards catheter ablation, because I think that's going to give them the best relief over time.
All right.
Iris, would you add anything to that?
You are absolutely right, Dr. Shah. And, building on what Dr. Jones said, the best time to ablate is actually early in the course of atrial fibrillation. And that's a paradigm shift for us as cardiologists and cardiac electrophysiologists. But you want to have the best possible, most effective treatment before the atrial fibrillation has rewired the electrical system and the pumping system of the heart. So, don't wait, ablate, and you'll have the best outcomes.
I like that. Don't wait, ablate. Okay. So thank you so much. Continue to ask your questions in the comments. Let's talk about implantable cardioverter defibrillator, or an ICD. Can we talk about those? What is that, and when is it indicated? Where is it placed? Dr. Shah, you want to take this one?
Sure, of course. An implantable cardiac defibrillator is a special type of pacemaker, and it's really reserved for only those patients that have life-threatening heart rhythm problems. Atrial fibrillation is not life-threatening. It's really a significant arrhythmia that we find commonly, but is not associated with what we call sudden death, where you can die suddenly from a very dangerous heart rhythm problem. So overall, we typically will recommend an implantable cardiac defibrillator if we believe a patient has either had a life-threatening heart rhythm problem. It's typically associated with an episode where they're going to lose consciousness, or if we believe they're at high risk for having a life-threatening heart rhythm problem. And that's when patient's heart muscle is really diminished compared to a normal heart function or normal heart strength. So that's not something that we use commonly for the management of atrial fibrillation, but some patients who have AFib may have an implantable cardiac defibrillator.
All right, thank you so much. What is the difference between an ICD and a defibrillator?
That's the same thing. So an ICD and a defibrillator are really the same thing. Those are specific, specialized devices that are there to observe dangerous heart rhythm problems and to deliver an electric shock in a life-saving fashion to return you back to your regular heart rhythm.
All right, thank you. Another question related to that. Can you talk a little bit about an extravascular ICD or an EV ICD and when this is indicated?
Sure, Cyrus, you want to handle that one?
Absolutely. So, as Dr. Shah said, implantable cardioverter defibrillator is like $1 million phrase. So we just say ICD or defibrillator for short. So for all the reasons that we as a field invented leadless pacemakers, we also recognize that the traditional ICD, that once again is transvenous, involves a wire running down your vein into your heart, may not be the best solution for every patient. So an extravascular defibrillator, and there are currently 2 on the market, MedStar offers both of them, is a reimagination of what a defibrillator is. The original defibrillators were invented all the way back in the 1980s, but by the early 2000s, we realized, well, if you're very young, or again, if you're prone to perhaps or higher risk for infection, a wire in your bloodstream may not be the best answer. So extravascular means outside of the bloodstream. An extravascular defibrillator is designed to protect your heart from sudden cardiac death and deliver an electrical shock to save your life, but nothing is inside the heart. So oftentimes these devices sit sort of in the armpit line here, and instead of going into the bloodstream and into the heart, the wire runs under the skin and along the sternum.
All right, thank you so much. More audience questions coming in,
Great.
and one of them is related to treatment. So I'd like to talk now about treatment options for AFib. Can we first start by talking about the types of medications that can treat AFib? And is that always the first line of treatment?
You want to handle that one, Manish, or you want me?
Sure, absolutely. Thanks, Harris. What I would say is that earlier in my career, I think there was a lot of emphasis on moving patients in a stepwise fashion in their management of atrial fibrillation. So we would start them on a medication, see if that medication worked. It, in general medicines, work about 50 to 55% of the time. That's not the greatest percentage. And so then we would move them slowly over to catheter ablation. But as I've gotten a little bit more experienced with ablation, I think we've really come to believe that ablation is really kind of the definitive therapy for atrial fibrillation. It's certainly not perfect, but it is far better than medicines in terms of its effectiveness. So there's been some studies now that have looked at catheter ablation as first-line therapy for atrial fibrillation management. And those studies have really shown that it is, as we would expect, because the success rates with catheter ablation can be as high as 80%. We know that for many of our patients, moving to catheter ablation essentially gets them to feeling better faster. And so in my personal practice, we will often go to catheter ablation as first-line therapy. Does it mean that some patients can try medicines? They certainly can. But in my opinion, many of those patients kind of languish in this purgatory where they're having continued episodes of atrial fibrillation despite taking medications, and that's a frustrating place to be. And so we can move them more quickly towards getting back to enjoying their life.
Thank you. Speaking of our audience questions, we have one from Carmel. Her question is, what are the differences in treatment for AFib versus SVT? Dr. Dottie, you want to take that one?
Well, I think that in general, we can approach both very similarly. So for both SVT and for atrial fibrillation, we like to offer our patients a choice. You have a little bit more of a conservative medication-based strategy. And as Dr. Shah said, even the best medications top out at around 50% effectiveness. Or you have a minimally invasive cardiac procedure called an ablation. So for atrial fibrillation, as Dr. Shah said, we can often see 70, 80% effectiveness rates. For many of the flavors of SVT, you can actually cure. You can have a 90, 95% success rate at permanently getting rid of the SVT and giving you your life back.
Thank you very much. Another question about treatment from Gail. Dr. Shah, I'll give this one to you. She's asking so earlier in the broadcast, we talked about symptoms of AFib, and we talked about sometimes you're asymptomatic. What about treatment for asymptomatic AFib? Can you talk about that?
I think that's a wonderful question. What we would say is the following. There's a few things that we know about atrial fibrillation. We certainly know that if you treat patients a bit earlier, we can reduce their chances of hospitalization. We can reduce their chances of really significant comorbidities, for example, like heart attacks, hospitalization. And so even though the difference is not a very large difference, there is a statistically significant difference between those patients when we're pursuing them for catheter ablation, even in the asymptomatic phase. Now, in general, we like our patients to feel better. And if you're asymptomatic to start, there's not a lot of room to improve on that. But in our patients who have asymptomatic atrial fibrillation, they still carry an elevated risk of stroke and they require some treatment for that. And we also know that atrial fibrillation is associated with some amount of cognitive decline over time. And so there is a lot of interest in studying asymptomatic patients to try to sense if we can go ahead and eliminate their atrial fibrillation, or at least significantly reduce the burden of atrial fibrillation, can we have positive outcomes in terms of cognitive decline? Now, obviously, those things need to be tested, and there are some studies that are going to be coming up really looking at that in detail. But that is an exciting new area in our patients who have atrial fibrillation when they're asymptomatic. But the bulk of our patients, we're really trying to help them with symptom management. In some patients, we know that we might be able to help them with some of the more hard endpoints like hospitalization, heart failure, and stroke. And so there is some impetus to push them towards catheter ablation.
Now, I'm going to be a little bit controversial and say that not everyone, but some people who say that they're asymptomatic, well, when you really talk to them, do you have symptoms? No. Well, do you still go play golf? Do you still garden? No. So, it's easy not to have symptoms when you have cut yourself off from the things that bring you joy because you can no longer do them. So I don't want to disagree with any of our lovely viewers, but I think a lot of people actually have subtle symptoms that go a little bit under-recognized.
Good point. Thank you. One more treatment question for you. Cardioversion. What exactly is that, and who is the procedure recommended?
You want to handle that, Dr. Shaw?
Yeah, sure, absolutely. Cardioversion is a simple temporary procedure. So if you've been diagnosed with atrial fibrillation for the first time, often we'll do an attempt at cardioversion. That's a procedure where you come in, our anesthesiologist will give you medications through the IV to put you to sleep. And then while you're asleep, we'll do an electric shock. And that electric shock will bring you back into your regular heart rhythm. The challenging portion of cardioversion is that we just don't know how long you're going to stay in your regular heart rhythm. For many of our patients, they'll often have recurrences of atrial fibrillation either the day after or perhaps a year after. But it is rare for a cardioversion to result in long-term freedom from atrial fibrillation. So we use it as a temporizing strategy to get our patients back into the regular heart rhythm so they feel better. And often we'll use it as a bridge to getting them to catheter ablation if they've had recurrent episodes of atrial fibrillation. Because catheter ablation is the solution that is, we're changing things fundamentally in such a way that will help them stay in their regular heart rhythm in a more permanent fashion. That's not achieved with cardioversion.
Cardioversion doesn't affect the drivers that put you into atrial fibrillation in the first place. So just a few days ago, I met a lovely gentleman. He's in his 50s. He's otherwise in great health. But a few months ago, he just started to feel that something wasn't right. And sometimes it takes a little while to recognize that you're in atrial fibrillation. So his family bought him for Christmas a smartwatch. And the smartwatch said, ding, 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 you're in atrial fibrillation. So we cardioverted him a week ago. And then this morning he called into the office to say that his smartwatch told him he's back into atrial fibrillation. And he has such a distinct difference in how he feels when he's in rhythm and out of rhythm that he said, give me your first possible date for an ablation procedure.
All right. Yeah. Thank you very much. Speaking of ablations, there's a audience questions about that as well. So I'd like to talk more about that. Catheter ablation. Let's discuss that first, just in general. And then can we talk about the newest type of ablation, pulse field ablation? Dr. Shaw, do you want to talk about those two, how they're different, and how new is pulse field ablation?
Yeah, I think those are great questions. I think that in our field, we are particularly excited about these new ablative technologies, predominantly because number one is that they are safer for our patients. So there are fewer risks associated with pulse field ablation, but also the durability and the success rates with pulse field ablation appear to be quite high, very comparable to prior strategies, perhaps even a bit higher. But the landscape of catheter ablation really started about 20, 25 years ago, and that involved using a heating technology that we call radiofrequency ablation. And that's what we call a thermal approach to treatment of atrial fibrillation, where we were heating up the tissue to cause injury around the veins that are bringing back blood from the lungs. And that's why we say it's a pulmonary vein, blood that's coming back from the lungs, isolation. We're electrically isolating those veins, because that's where those little triggers, those firings are happening from the veins. And so we used a heating technology called radiofrequency energy, reasonably successful, was really in prominent use from the 80s all the way to, 2010s, was the dominant form. The issue is that sometimes patients would have recurrences because we would leave a few little electrical gaps between our heating treatments. And so patients can have recurrences. I think in about 2010 or so, we started using a freezing modality that was called cryoballoon therapy. And that freezing modality was a little bit more conducive to many of our patients because the procedure was a little bit faster, a little bit safer for our patients. And the effectiveness of it was pretty comparable to radiofrequency energy. And I would say that from 2010 up to, really 2024 was the mainstay for many institutions to use, a combination of one of those thermal strategies, heating or cooling technologies, to really try to get rid of the atrial fibrillation for most of our patients. Now, in Europe, starting in about 2021, they started using a very new technology that is not heat or cooling based. So we say it's a non-thermal strategy, and that was pulse field ablation. It actually uses very large electric fields to cause injury to the tissue. But the big advantage of that technology is that it was very specific for heart muscle tissue. The consequence of that is that patients would have fewer issues with structures around the hearts. For example, the esophagus, which is the tube which connects your mouth to your stomach. We reduce the chances of injury in that space. We also reduce the chances of injury in the pulmonary veins that we're treating. And so there are multiple reasons why we think that pulse field ablation really is here and is really going to be the dominant energy source in the future. At our hospital in MedStar Washington Hospital, and I also know certainly up at Union Memorial and Baltimore area, that really pulse field ablation is really accounting for 95+% of the cases that we do with catheter ablation, excuse me. And so we think this is the wave of the future. It's faster, it's simpler, it's safer for our patients. Cyrus, you want to add anything there?
Well, first, I think, Dr. Shaw, you're being a little humble. You are one of our master afibrillators, and you were on the FDA trials that approved the use of pulse field in the United States. So if you come to MedStar, you get a nationally renowned ablation with Dr. Shaw. And again, I think I have to toot MedStar's horn. MedStar has really been very proactive and future-oriented and invested heavily in these new pulsed field ablation technologies. If you go to other hospitals in the area, you do not have the access to pulsed field ablation. And so many of our cardiologists, many of our patients are smart. You can look on the internet and read all about this new technology. You can read that it is faster, less time under anesthesia, safer. And so people come to us asking for pulse field ablation, or PFA by name. And we really are very, very excited about it.
That's wonderful. And you mentioned it's faster. How long does that procedure typically take, and what is the recovery time?
Yeah, I mean, I would say that it's possible for us to do catheter ablation now in probably about 45 minutes. And the total time under anesthesia is about an hour or less. So it's really moved us into, a very straightforward, simple procedure with very few risks for a patient. And that's been a major shift for us within the last year or so. There were patients that we would previously hesitate to take to catheter ablation because the procedure could take 2 to 3 hours. And now when we can do just an effective job, if not more effective, in under an hour, patient is able to recover in a few hours after the procedure and go home shortly thereafter. Those are really strong benefits for our patients, and it's really moved it into an outpatient setting.
Manish, I was telling Karen earlier that I think when I was a trainee physician, I expressed an interest in ablation. And so the electrophysiologist invited me to observe an atrial fibrillation ablation with the now very old thermal technology. And I think it took about 6 hours. I literally fell asleep. And I remember the attending very rudely waking me up saying, I thought you were interested in this. How could you fall asleep? And so it really is just such a sea change in how safe and how fast it is for our patients now.
Yeah, absolutely. I couldn't agree more. We dread those days of those 6-hour procedures. And, now I think we feel much more confident in our ability to take care of those patients safely, effectively. So we're excited on all aspects.
Yeah, it sounds great. It sounds like it's the gold standard now.
Of course.
I would say
Wonderful.
so. Yeah.
Yeah. So I have a question from Jean, who's watching. Thank you, Jean. She's asking, does an ablation last, or does it need to be redone?
So I think that's a very sophisticated question. If we're talking about SVT, the flavors of SVT, as we said, often an ablation is curative, one and done. With atrial fibrillation, we're still not at the point where I can say that I can cure you with 100% confidence. We were saying that the best medicines, the strongest medicines, the one that carries a lot of side effects, unfortunately, tops out at about 50-55% effectiveness. With pulsed field ablation, we think that we can get up to about 80% effective, but that does mean that there are going to be some folks who don't always get maximal benefit from the first ablation. And sometimes a few years later, the atrial fibrillation might start to creep back and you need a touch-up procedure. And again, this is where I say the earlier we diagnose your atrial fibrillation, the earlier we can treat you before you have electrical or structural changes in your heart, the better you're going to do.
Thank you so much. I know, Dr. Shaw, you need to drop off to take care of patients. Thank you so much for joining.
You're in great hands with Dr. Haddadi.
Yes.
Trust everything that he says.
Thanks, Manish.
Thank you so much for joining. All right, Dr. Haddadi, I have a couple more questions for you.
Of course, yeah.
So speaking of, going back to ablations, we have an audience question, and I think we touched on this about curing AFib, but this question is, can ablations be a permanent cure for AFib?
So I would say yes and no. I don't use the word cure. I deliberately borrow from a cancer doctor and I say, I want to put your AFib in remission. When I do an ablation, I'm creating a clock, and that clock is how long until AFib comes back. If we've created 20 years of freedom from AFib, that's amazing. That could be the rest of the natural lifespan that God has given you. 10 years, great. 5 years, that's pretty darn good, right? Unfortunately, as I said, sometimes we meet somebody who's been in AFib for years and years and years, and the heart has electrically rewired itself to be very resistant to coming out of atrial fibrillation. And for those patients, it's not impossible, but it's more difficult. And sometimes you need a longer procedure, or sometimes you do need a second touch-up procedure. So the younger you are in the course of your atrial fibrillation, the better your outcomes are going to be.
All right, thank you. And I have a question from Rebecca about ablations. She asks, what's the difference between an ablation and what an AED delivers?
Okay, so that's a wonderful question. I assume by AED you mean one of the external defibrillators that we often find in public at the airport or at sports events. So these are a little bit different. an ablation is a treatment for an irregular heart rhythm. An AED is a life-saving device. It's an external implantable cardioverter defibrillator that's there so if somebody, God forbid, has a sudden cardiac arrest or sudden cardiac death, folks can grab the AED and see if an electrical shock can bring you back to life. I think we've all seen on TV, sometimes even young, totally physically fit sports athletes can have a cardiac arrest. And so the AED is there to prevent the dangerous heart rhythm, stop the dangerous heart rhythm, and bring you back to life, save your life.
All right. Yeah. Thanks for explaining those differences. And thanks
For
for
sure.
your question, Rebecca. One more ablation question from our audience, and then I have one more to wrap up this
Absolutely.
discussion. This question's from Thomas. Can you explain mapping?
Of course. So when we are doing an ablation procedure, we have many tools to help us get the best outcome. So in the old days, all we had was the X-ray machine. A more modern approach to ablation incorporates not just X-ray, but an echocardiogram probe, whether it's using a special tool that also is advanced up from the groin. And then mapping actually uses a very powerful computer to build a 3D picture of your heart as we work. So it does two things. It minimizes the need for X-ray and your exposure as a patient to X-ray, but then it also allows us to be really, really precise. So believe it or not, our ablation catheters all have tiny GPS chips embedded in them. And so in every one of our electrophysiology procedural rooms or operating rooms, we have a tiny magnetic field. So when I am doing an ablation procedure for you, and I am moving the catheter inside the heart, we know within a fraction of a millimeter exactly where we are in three-dimensional space. When we integrate all of that data to create a 3D model of the heart, we call that a map. And so the map can help us tell where healthy heart tissue is and where sicker heart tissue, that could be the origin of the arrhythmia, is. And when we're doing ablations, the map can help us determine where the source of the arrhythmia is with really, really nice high resolution detail. Mapping is what helps us achieve cure rates of 90 or 95% in SVT ablation, and it helps us get better outcomes in atrial fibrillation ablation.
Thank you. So my last question, it's related to one from our audience from Gail. And that is, how do you determine what procedure or treatment is best for the patient? And Gail was asking, are there tests that are done to
For
get
sure. So in general, my philosophy of care is I want my patients to decide. I want to present to you my thoughts as an electrophysiologist, and you will help me come to the best treatment strategy. For SVT and for atrial fibrillation, oftentimes you can pick between a medication-based approach and an ablation-based approach. And a lot of my patients just don't want to be on medicines for the rest of their lives. So I really believe in patient choice and agency. Sometimes the choice is very black and white. There are some unlucky people where your arrhythmia can cause weakening of your heart, a condition called cardiomyopathy or heart failure. And we know that in these folks, if you do an ablation to correct the irregular heart rhythm, the arrhythmia, you can oftentimes improve the strength of the heart and prevent heart failure. So in those folks, I think the decision is very clear. An ablation will help you live your best life and be in your best health. So again, talk to your doctor. At MedStar, we love meeting patients.
Thank you so much.
Of
So we have a
course,
few
thank
minutes
you.
left, and I wanted to talk about, so earlier in the broadcast, we talked about how AFib can increase your risk of stroke.
For sure.
When you have AFib, yeah, you have that increase. The left atrial appendage the left atrial appendage occluders are used to reduce the risk of stroke in AFib patients. Can you talk about that and exactly how that reduces the risk?
Absolutely. So I regret that Dr. Shah had to run, because actually Dr. Shah is in many ways, our left atrial appendage occlusion champion. He has done by far the most here at MedStar Washington Hospital Center. But briefly, because I know our time is a little bit limited, you have a pouch in the top left chamber of your heart called the left atrial appendage. And so just like you have an appendix in your intestines that maybe did something millions of years ago, but these days just seems to cause appendicitis, this pouch, the left atrial appendage, is the source of about 90% of the blood clots that cause strokes in atrial fibrillation. So when we first realized that, the answer was, well, do open heart surgery and cut the pouch off. And that works, but it's really, really invasive for our patients. So over the past decade or so, we have come up with percutaneous, that means minimally invasive, not open heart, ways of closing that pouch off. So the two most commercially utilized left atrial appendage occluders, or devices that close off the left atrial appendage pouch, are the Watchman and the Amulet. And they both work in a very similar way. Under anesthesia, I will make a tiny incision in your groin, and I'll load the folded up device, folded up like a little umbrella at the tip of a catheter. We'll very carefully navigate it into your left atrial appendage, and then we'll open it up. And so it will close off the appendage. It will prevent blood clots from leaving the appendage and causing a stroke. And so over the next few weeks to months, as the body incorporates it, you can stop your blood thinners. So you have all the benefits of being protected from a stroke without having to be on blood thinners any longer. And here at MedStar, we are again participating in many FDA-run clinical trials to bring you the best and the newest technology in this area.
Great to know. Thank you so much. So if our viewers are thinking, I might have AFib or another heart rhythm disorder, what do? There's actually a question from Lori. Can a cardiologist just order a heart monitor? Will it show up on an EKG? What should our patients do?
We have many sophisticated tools now. That is a great question. Your internal medicine doctor, your family medicine doctor, your general practitioner can all order EKGs or heart rhythm monitors. Your cardiologist certainly can interpret that EKG and heart rhythm monitor to look for atrial fibrillation and then refer you to us, the heart electricians. And what's really, really interesting is, I told you about my 50-year-old patient who found atrial fibrillation because his smartwatch told him that he was having it. So this is huge for our field. Now, for the first time, you have Apple Watches, you have Fitbits, you have all of these devices, the Cardia Mobile that you can buy on Amazon, that can check an EKG at home and alert you to possible atrial fibrillation before, God forbid, you have a stroke. So all of these tools can be used to look for atrial fibrillation, to diagnose you early, and to get you a really durable treatment and give you your life back.
That's great to know. Thank you so much, Dr. Haddadi. We talked a lot,
Thank you.
had some wonderful information that you shared today. I know our viewers appreciated it. There was
Viewers,
a lot of
smash
engagement
that
on the
like button.
So before we wrap up our discussion today, anything you want to make sure that our viewers take away from our conversation, or anything else you want to say before we adjourn?
I think as a heart rhythm specialist, I have the best job in the world. I get to meet lovely patients and I get to really help them feel better on a day-to-day basis. If you have noticed that you just don't feel like yourself, it could be many things. but it could be a heart rhythm disorder. So I encourage you to meet with your doctor, meet with your cardiologist, or get a referral to a cardiologist. And then if it turns out that you do have the signs and symptoms of an arrhythmia, here at MedStar, we have the latest and greatest technologies to help you to feel better.
That's great. Well, thank you so much. With that,
Thank
that's
you,
all the
Karen.
time we have for today. Thank you again to our viewers for watching. Thank you to our experts for joining. For more information, we will post a link in the comments. Thanks again, and we'll see you next time. Bye.
Fantastic. Thank you. Thanks, everyone.